I'm Dr. Shawn Tassone. Welcome to Confessions of a Male Gynecologist, a podcast dedicated to women's health and hormones, and pretty much everything else you were never listened to when you went to the doctor's office. I'm board certified in OBGYN and integrative medicine, and I have a PhD in mind-body medicine. I guess you could say I'm a little bit outside of the box. In this podcast, I'm going to get you the answers you probably asked 5 other doctors and were kind of blown off. I want you to know that I'm not only here to talk, I'm here to listen as well. And now, let's get to those confessions. Hey everybody, welcome back to another episode of Confessions of a Male Gynecologist. I'm your host, OBGYN, and board certified in integrative medicine as well. Seeing patients live here in Austin, Texas. I also see patients across the country in 48 states via telemedicine. So you don't have to be in Texas. You can be in a different state. And I can still see you. The only states I'm not in are Massachusetts and Maine. So please give me a call at the office, 512-956-0296, if you have any issues with your hormones, like you're not getting the help you need. You can't get labs drawn. You can't get anybody to listen to you. I do this all the time. I wrote the book, The Hormone Balance Bible. It's available on Amazon. Talks about the 12 most common hormone imbalances in women. And you can get that for about $14 to $15, depending on the week, because Amazon changes their prices all the time. So go ahead and get that book. It's a good starting point. You can also go to my website and take my 36-question hormone quiz at tassonemd.com/quiz. I will ask for your email address, but it's free otherwise. I also have a monthly meeting that I do for free called the Dr. T's Evidence Edit, which is where I go through a journal article, teach you how to read it, teach you what's relevant, what's not relevant, and just kind of keep you in the know. So when these scammers online make these weird claims, that you can reason through that and figure it out for yourself. In the last 2 weeks, I've spoken about estradiol and testosterone. And this week, I want to talk about progesterone. And this will be a pretty easy podcast to listen to. We'll make it simple. Bioidentical progesterone. So there's 2 types of progesterone. There's bioidentical progesterone. There's a progestin. Progestins are what are commonly seen in things like birth control pills, IUDs. There are oral progestins like agestin, norethindrone, and medroxyprogesterone. The problem with progestins is while they will act, or they have progesterone-like actions in the body, they don't fit the keyhole perfectly like progesterone does. So you don't get a lot of the benefits of a progesterone, like sleep, calmness, less anxiety, and things like that. So it's something that you need to look at. Now, if you have a uterus and you're menopausal, you have to be on progesterone to protect the uterine lining. If you don't have a uterus because you've had a hysterectomy, then you don't need to take progesterone to protect the uterus. And I have a lot of women that will come to me and say, well, my doctor wouldn't prescribe me progesterone because they said I didn't need it. That's true. You don't need it to protect you from uterine cancer, but you could need it for sleep or need it for anxiety and other things. So it's one of those things that need is kind of a weird way to say it. But if you're suffering with anything, please get checked out. So what is progesterone? Progesterone is a hormone that's made mostly in women in the corpus luteum. So the corpus luteum, after you ovulate, are the cells that are left behind, and that corpus luteal tissue makes progesterone. Progesterone stabilizes the lining, it thickens the lining, gets you ready for pregnancy. If you get pregnant and you have implantation, the progesterone will feed back to the and support the placenta for the first 10 weeks of your pregnancy. So it's super important. But progesterone is also peaking in a woman that doesn't get pregnant around days 19 to 21. If there is no implantation or pregnancy and the corpus luteum doesn't get feedback from an embryo with beta HCG or human chorionic gonadotropin, then the corpus luteum starts to regress on about day 21 and your progesterone levels fall. So you really only have about 2 days in your cycle when your progesterone's really high. When women have PMDD or PMS, what we tend to see are lower levels of progesterone. And sometimes that doesn't feel good. Now, keep in mind, you always have these fluctuations in your progesterone and in hormones in general. But progesterone has more of an influence beyond just reproduction. The perimenopausal and menopausal symptoms that can improve with progesterone, as I talked about, sleep disturbances. That's number one. I get so many women that come see me and they can't sleep and they're miserable because they're not sleeping. Many women notice difficulty falling asleep. And I would say if I had to stratify sleep, I would say most women have more issues if their progesterone is low, falling asleep, not staying asleep. Staying asleep tends to be multifaceted. And in many of my patients, I can get them to fall asleep and some still have issues where they don't stay asleep. That's usually habit, melatonin levels. But what happens is progesterone has a metabolite. It breaks down into something called allopregnanolone that progestin does not do. And that's why the fake progesterones don't give you this effect. Progesterone will break down into allopregnanolone, and that interacts with a receptor in your brain called a GABA A receptor, which produces a calming effect and that sleep pattern. So when you have allopregnanolone, you sleep better. When you don't sleep as well. You don't feel as calm. You might have more anxiety and irritability. And progestins aren't going to help you with that, just progesterone. Fluctuating or low progesterone levels can influence mood and anxiety because progesterone is a neurosteroid, or it influences neurosteroid activity in the brain. And this has been studied as early as in like 1990s. We have known about this. So we know, and I have some friends out there that are psychiatrists that actually don't buy into that. They will tell you that progesterone doesn't help with anxiety. I will tell you that's just not right. We have studies that show that. We have studies that show women do feel better. And I see it almost daily. I can't tell you how many patients I see every week, probably 80 to 100. And across the board, women feel better on progesterone. So what about night sweats and hot flashes? That's, we usually think of hot flashes and night sweats as being an estrogen deprivation syndrome, and it usually is. But progesterone in combination with estrogen may actually enhance the effects of the estrogen on night sweats and hot flashes, because progesterone has a stabilizing effect on your blood vessels. So women, like another thing, women that have migraines, if they are hormonally mediated, progesterone can have a stabilizing effect on that blood vessel. And so you may not have as many migraines. Like I've had, off the top of my head, a few women that have really bad migraines, like 3 or 4 a week. Noticeably, when I start them on progesterone, they'll probably tell me their headaches have been cut in half, which is fairly substantial. I mean, I used to be a migrainer for probably 20 years of my life. And when you start having them that frequently, it really gets hard to live your life because you're just miserable. And then you're constantly wondering when the next migraine's going to come. And to not have those migraines can substantially change your life. Women that are in perimenopause, irregular, heavy bleeding, progesterone opposes the effects of estrogen. So what progesterone is going to do is it's going to downregulate the estrogen receptor status in your body. So it kind of is a give and take with estrogen. While estrogen, if you think of estrogen as being the fertilizer and the water on the lining of your uterus, progesterone is like a stabilizer. And then also when you remove the progesterone, that's like the lawnmower. So progesterone stabilizes and thickens. When it falls dramatically, the lining becomes destabilized and you shed. That's when you have your period. So women that have irregular periods, maybe they're having a period every 3 to 4 months, they're getting unopposed estrogen for 3 or 4 months. That can be from PCOS or from perimenopause or things like that, and obesity and insulin resistance. And sometimes just adding progesterone to their life can make a massive difference. Cognitive fog, brain fog. I tend to think of brain fog, I have a lot of women that are older that are worried about dementia and whatnot. Brain fog is not like you're forgetting your kids' names or important things. You're just forgetting, like, a word here and there. You can't quite place it. Or you might, forget where your keys are. You're just scatterbrained and you can't quite put things together. But that doesn't mean you're getting dementia. And that's a real fear. We talk about dementia a lot in my visits because people have family members and it's scary. I also think that brain fog is part of aging. I get that. I mean, I can do a surgery and operate the robot, but I might forget, a word or two here and there. And it freaks me out because I'm like, why can't I remember this word? But it's part of the aging process. And it could also be stress and that you're busy, you didn't sleep well. But what happens is progesterone is responsible for a healthy cycle. So if you're not cycling regularly or if you're having heavy, painful periods, sometimes adding progesterone can help. Breast tenderness and bloating. Bioidentical progesterone can reduce estrogen related fluid retention. So sometimes women, and I tell all my patients this, when you start on estrogen, let's say you're 55 and you start estrogen, you're probably going to gain about 5 pounds because estrogen is going to help retain fluid in your body. It's going to retain fluid in your muscles. It's going to retain fluid in your joints. This is water that was already in your body, but we went into menopause over a couple of years. You slowly lost that water. And I think that's why a lot of women have muscle pain and joint pain when they're in menopause is because that fluid's gone and it helps lubricate, it helps keeps things soft and spongy, and then that goes away. So when you gain 4 or 5 pounds from starting estrogen, please, please, please don't freak out. I know we get on the scales too much, but it's one of those things where that's water that's already been there. But the beautiful thing about progesterone is that it's a natural diuretic. And so you can see where these things play off of each other. Estrogen retains the fluid, progesterone gets rid of fluid. Bioidentical progesterone can reduce the estrogen related fluid retention and sometimes breast pain. But I will tell you, I do have patients that when they start progesterone, and I usually tell patients this, when you start estrogen and progesterone, the two tissues in your body that are super sensitive to those two hormones are your breasts and your uterus. So when you're cranking those engines back up and you're restarting everything, those two tissues are going to get stimulated. So you can have breast tenderness, you can have nipple sensitivity, cramping, even spotting. Usually that goes away in a few weeks. It might take in some people 3 or 4 weeks, depending on the dosages. But if you've been on hormone replacement for months, and you still have breast tenderness, chances are you're just on a dose that's probably a little too high. And that could either be estrogen or progesterone. Bone support. We don't think of progesterone as a bone supporting hormone, but progesterone can aid in bone formation, particularly when combined with estrogen replacement. In some trials, and I know a certain doctor out there that talks about cycling progesterone, but in some trials, cyclic progesterone has been associated with increased bone formation markers. Not necessarily bone formation, but the markers of bone formation. She'll go out there and talk about that and make it sound like doctrine. It's not doctrine. The reason that estrogen works on bone is it suppresses a cell in your body called an osteoclast. And osteoclasts eat your bone up so you can remodel your bone. Well, if you slow down that eating up of the bone, you'll retain more bone. Testosterone, which we talked about last week, will actually build back more bone. So the combination of estrogen and testosterone is actually a 1-2 punch. Because progesterone can downregulate those estrogen receptors, you could get a little less of that protection from that cell that's eating your bone because remember, you downregulate estrogen receptors. So the thought process would be that cycling progesterone might help with that. I can tell you, I've been doing this for 25 years and I see women reverse bone loss all the time and they're on progesterone. So progesterone isn't going to make you lose bone. I don't think a 70-year-old woman or a 60-year-old woman needs to have a period just so she can theoretically protect her bone. And then the question would be is why? Why then do I have to do bioidentical progesterone? And you don't have to if you don't want to, but why wouldn't you want to take something that looks more like your body's natural hormone? I don't know. The term bioidentical means that the hormone's molecular structure is identical to your regular progesterone. Micronized bioidentical progesterone, whether it's compounded or commercially available, will bind to the progesterone receptor the same way that your naturally producing progesterone does. And I think people get confused, and I've talked about this many times, between bioidentical and synthetic. Synthetic means that it's made in a lab. All bioidentical hormones are synthetic. It's not like you can pick up a rock and there's progesterone. They have to make the progesterone in a lab. They usually make it from soy and wild yam. So it's natural, but it's synthetic because it's being made. So don't get caught up in the whole jargon of synthetic versus, they're all synthetic. Doesn't mean they're not good for you. It just means they have to make them, which is fine. That's how we do things. And that's for all the hormones. What I think people get confused with, especially with the other hormones, but it's compounded versus commercially available, right? Commercially available means you can get it at Walgreens, CVS, Costco. Compounded means you go to a specialized pharmacy and they make it for you. Bioidentical progesterone has been on the market commercially available for over 20 years. It started out as a medication called Prometrium. Now it's generic. It should just say micronized progesterone. So if you're going to CVS, if you're going to Walgreens and you're getting micronized progesterone, that is bioidentical. The only downside to getting it from one of those pharmacies is if you have a peanut allergy, because it is in peanut oil. If you have a peanut allergy, we have to compound it. Also, what are the routes of delivery of progesterone? This also gets a lot of issue because there's a lot of women out there putting progesterone up their butt. They're putting it in their vagina. I get people asking me all the time, why are women putting progesterone in their butt? I don't have an answer for that. It's really unnecessary. There's oral capsules. Micronized progesterone is usually taken orally at bedtime. Been around for 20 to 30 years. We know that the levels that you get from oral progesterone protect the uterine lining. It's been studied. I always start with oral progesterone. Transdermal creams or gels applied to the skin, they bypass the liver. The problem is we don't have any studies to show that topical progesterone is enough to protect the uterus. So if you don't have a uterus and you don't want to use oral, you can try topical. I don't usually use topical because, in my opinion, the progesterone molecule is so big that it's harder for it to absorb through the skin. I don't see women have the same effects usually topically that they would get orally with progesterone. So unlike estrogen, which I start topically, I usually start bioidentical progesterone orally. Vaginal capsules and creams deliver the progesterone. Here's the thought process. Well, if I put it in my vagina, it's going right to the uterus. Well, no, it's going everywhere because blood vessels go everywhere. It might hit the uterus first. They're also out there saying it absorbs better. It's the same as if you put it in your mouth. The mouth and the vagina both have an abundant blood supply. They're both mucosal membranes. My theory is, why would you want to put a messy suppository in the vagina every day, especially if you're having sex with a partner who might get the progesterone on their penis? I just don't see it as a good route. And then to do it rectally, that's just sheer stupidity. And what you're going to have is, here's the thing. If you have a provider, health coach, somebody online that's telling you to do something outside of the usual method, and they act like they've discovered something that the medical system doesn't want to tell you, they're making stuff up. Because these have all been tested and they work fine. So when they come up with something, and I say this all the time, the hormone lane online is very noisy. Everybody's a freaking expert, except they're not. And in order to separate themselves from the real experts who know something, they make stuff up. They make up putting progesterone in your butthole is better for you. And it's totally stupid. So I would not take progesterone through the vagina or the anus. I just think it's ridiculous. So individual responses to progesterone are obviously going to vary because you're all different. But what you could potentially expect, fewer night sweats and hot flashes, especially if you're using it with estrogen, more restful sleep. Hopefully you don't wake up as much, a calmer, less wired feeling at night, an actual reduce in bloating and breast tenderness compared to progestins. So you still might get bloating because progesterone can slow down the GI tract so you can retain more gas and stuff, but that's usually for a few weeks. Usually your body readjusts and fixes that. You can have relief from uterine bleeding and uterine irregularities, bleeding irregularities. Put almost every patient on progesterone that's in menopause because I want them to sleep, because I want them to have the calmness. Now I give them the option. Obviously, I usually will tell them, hey, if you don't have a uterus, you don't need to be on progesterone. But 90% of the time, those women are struggling with sleep. So I want them to feel better. So they always try it. And most of them stay on it. I would say out of all the hormones, progesterone is probably the fastest acting hormone. Like many women will start sleeping better that night. The one thing I experienced, and somebody asked me to talk about this, actually, a lot of women did, is this concept of progesterone sensitivity, meaning we prescribe 100 milligrams of progesterone and you either feel wired or you have some other untoward reaction that you don't like. It's kind of fascinating to me because most women, or you all have progesterone in your body during your reproductive life, and you don't usually have that issue. But some women will have that, and it might be just because of the dosing. So I have never had a patient that I haven't been able to get on progesterone eventually that has sensitivity. So what I normally do, the starting dose that's commercially available, there's only 2 doses, 100 milligrams and 200 milligrams. If I have a patient that has progesterone sensitivity, I will compound 25 milligrams or 12 and a half. I've gone even that low. And then I'll keep them on that for a month. And then I'll move them from 25 to 50, 50 to 75. And eventually we can get them up to 100. It's just, so don't give up the ship. And if you find a doctor that is just saying, well, that's all I got, you only get 100 milligrams, find somebody that will do it that way. You don't need to go to vaginal. You don't need to go to rectal. You can do it compounded. It might cost a little bit more, but I think that's the way that you should do it. So basically, we covered estrogen, we covered progesterone, we covered testosterone. I think I'll probably cover thyroid. We've already done some on thyroid, but it's always good to have a refresher. Remember, if you're struggling, if you can't find help, or if you feel like, I have a lot of women that will call me and tell me they don't feel like their practitioner is really in the know per se, like they just don't check levels and they're just guessing, give me a call. If you call this month, which is December 25, and say Merry Christmas to my staff because I'm so mean to them, they need somebody to say Merry Christmas to them. You'll get $100 off, and I'll send you a free copy of my book. You don't have to be seen in December. You just have to make the appointment in December and get signed up. And you can call the office 512-956-0296. Y'all have a good week, and I'll see you on the flip side. Thanks for listening. If you enjoyed this episode and you'd like to help support the podcast, please share it with others, post about it on social media, or leave a rating and review. To catch all the latest from me, you can follow me on Instagram at Shawn Tassone MD, or on Twitter at TassoneDoc, and on Facebook at America's Holistic Gynecologist. If you're really interested in your hormones and you want to do a deep dive, get my book, The Hormone Balance Bible, on Amazon or other major retailers. Thanks, and I'll see you next time.